This is Chapter 2, Reproduction. Sexual differentiation in the embryo. Sexual maturation actually starts during embryonic development and it becomes fully mature in late adolescence. So you can see how when the embryo starts to develop, that maturation starts right then because sex is determined at conception. But it takes about 8 weeks before the reproductive system actually becomes differentiated as male or female. So we'll talk a little bit more as we talk about the embryo and developing into the fetus. And then as we get into pediatrics, we'll talk more about sexual maturation in adolescence. So the external structures of the female reproductive system, you can review the anatomy on your own. You've already had anatomy class, but just as a refresher, you can look at figure 2.1 on page 26, and then it goes through those, gives you information about each one from page 26 to 27. And then looking at the internal structures of the female reproductive system, there is a figure on page 27, 2.2, figure 2.3 on page 28, and also figure 2.5 on page 29. So you can review that as well for a refresher. I am going to go into a little bit more detail about the uterus because I want you to understand the structure and function of the uterus. So the uterus is divided into 3 different sections. So you have the corpus, the isthmus, and the cervix, and I'm going to tell you about each one. So the corpus is the green on your picture here on the slide. This is the upper 2/3 of the uterine body. And this is where the fertilized egg implants. So the corpus is actually the part of the uterus where it implants. There are 3 layers of the corpus: the perimetrium, which is the outer layer, the myometrium, which is the middle layer, and the endometrium, which is the inner layer. And so there are 3 layers of that, and then the endometrium itself is composed of 3 different layers, and 2 of these layers are shed during the menstrual cycle. So just keep in mind the corpus is the upper 2/3. That's where the fertilized egg implants. It's made up of 3 different layers. The endometrium is the innermost layer, and that 2 of the layers of the endometrium are shed during the menstrual cycle. Now the isthmus is the area between the corpus and the cervix, so that's the blue part on your picture, and this is where the uterus starts to narrow. And then the cervix is the lower portion, which is the yellow part on your picture, and this is where the uterus begins to open to the vagina. So the function of the cervix, there are several different things that the cervix does. It transports sperm into the uterine cavity, it allows blood to escape during menstruation, and it secretes mucus, which will lubricate and protect the vaginal canal. Now, during pregnancy, the cervix forms a mucus plug, which will protect the pregnancy from outside pathogens. So in the cervix during pregnancy, a mucus plug is formed, which will actually keep any type of pathogens, any type of bacteria, anything like that from getting to the baby. And the cervix is also where the cells are scraped and screened during a pap smear when a female goes to the gynecologist. So that's where they're looking for those cervical cell changes from that cervix. Then there are uterine support structures. So the position of the uterus in the body varies by age, the woman's age. Pregnancy obviously changes the position of the uterus, and a distension of related pelvic viscera. So any other things in the pelvis can also cause the position of the uterus to change. Typically, the uterus will lie over the urinary bladder, okay? Now, the uterus is supported in the pelvis by 5 different ligaments, and you can see those ligaments listed here on the slide. The broad and round ligaments will support the upper portion of the uterus. The cardinal, pubocervical, and uterosacral ligaments support the middle portion. Then you have pelvic muscles, which actually support the lower portion of the uterus. And if you look on page 30 in your book, figure 2.6 shows you the pelvic muscles and shows you the ligaments as well. So page 30, figure 2.6. Then the vagina is a muscular canal that is approximately 4 inches in length and that extends between the uterus and the perineal opening. So the mucous membrane of the vagina is arranged in rugae, and it lines the smooth muscle of the vagina and allows distension during childbirth. So we also want to look at the pH of the vagina. So it's typically acidic, 4.5 to 5.5 during reproductive years, and that helps protect the genital tract from any pathogens. So that pH is very acidic, so it can kill any bacteria or anything like that that may be present, that's not supposed to be present. Pelvic anatomy. Now this is important to really focus on and pay attention to, especially during childbirth, okay? So the bony pelvis is a very important structure in the female anatomy because it supports and protects the internal reproductive organs. And it also provides a passageway for the fetal head during birth. So that's why the bony pelvis is very important. It's protecting our internal reproductive structures and organs, but it also provides that pathway for the fetal head during birth. Now, there are 4 bones of the bony pelvis. You have the sacrum, the coccyx, and 2 innominate or hip bones. Okay, so look at page 30 in your book. Figure 2.7. This is showing you the bony pelvis, okay? Now, the pelvic floor consists of soft tissues that provide support and stability for the surrounding structures. So that's the floor of the pelvis. Now, this is important, and this is what the picture on your slide is. There's a true and a false pelvis, okay? So this is 2 different sections of the pelvis. It's not 2 different parts, but it's 2 different sections of the bony pelvis. So the false pelvis, which is the left-hand picture, the function of the false pelvis is to support the lower abdominal organs, but it has very little to do with childbirth besides just directing the presenting part of the fetus towards the true pelvis. So if you see the false pelvis, that's the highlighted part on the left-hand side. Okay, so really it's supporting the lower abdominal organs, but not really much related to the childbirthing process. Now, the true pelvis, on the other side, you see the highlighted part on the right-hand picture. This is the part of the pelvis that is important for childbearing because this area must be large enough in diameter, so across, to accommodate the fetal head during delivery. And we're going to talk more about this on the next slide as far as the diameter of the pelvis. So, pelvic diameters and planes. So as I just mentioned, that the diameter of the true pelvis has to be adequate to deliver the fetus. So to determine this, a healthcare provider can use what's called pelvimetry, which is the measure of this pelvic inlet, the mid-pelvis, and the pelvic outlet. So look at these 3 portions right here listed on the slide. Those are the portions that would be measured to determine adequacy of being able to deliver the fetal head, okay? So during labor, the ischial spines, look at this picture on the slide. These red marks right here are called the ischial spines, okay? These serve as a landmark for assessing the level of the fetal presenting part in the pelvis. And when we talk later in a slide, when we get to the labor and delivery part, in a different chapter, we will talk about the fetal presenting part and what that means when we talk about the station. Okay, so keep in mind, I'm showing you the picture right here of the ischial spines, the red on your slide here. That's what serves as the landmark for assessing the level of the fetal presenting part. Okay. During pregnancy, the joints of our pelvis soften and become more flexible because of hormones, and that creates this additional space to accommodate the childbirth. So it's really amazing what our bodies do in preparing for childbirth. So hormones will actually help relax, soften and relax our pelvis to allow it to accommodate the baby. Pelvic types. So there are 4 different types of basic bony pelvises, and we're going to just mention these briefly. So gynecoid, This is your typical traditional pelvis. This is what is best suited or situated for childbirth, okay? Android resembles actually a male pelvis and is harder triangle shaped. This type of pelvis can cause difficulty during fetal descent. Anthropoid is similar to the gynecoid, but the suprapubic arch may be narrowed. It is oval shaped and it can cause posterior fetal descent. And platypeloid is broad and flat. It really bears no resemblance to any lower mammal form. This type of pelvis can cause fetal descent to be transverse, which is across, and this type of pelvis will not allow for a vaginal birth. So look on page 32. Figure 2.9 actually shows you these different types, how they look, that we just discussed. So page 32, figure 2.9. Breast anatomy and function can be reviewed on your own from page 32 over to the top of page 33. And there's also a picture on page 32, figure 2-10, so you can review that on your own as well. So let's have a knowledge check. True or false? The false pelvis has an important function during the birthing process. So is that true or false? So it is false. Remember, the true pelvis is what is important for childbearing. So make sure you go back and look at those pictures on the slides previously. The interplay of hormones and reproduction. So hormones are released by the hypothalamus, and these simulate the release of other hormones. And we're going to just briefly talk about some of these. You can look at page 33 where it talks about all these different hormones. There is gonadotropin releasing hormone, which stimulates the release of gonadotropin follicle stimulating hormone and luteinizing hormone. In premenopausal women, gonadotropin affects the cyclic process of follicular growth, ovulation, and maintenance of the corpus luteum. In the male, gonadotropin affects spermatogenesis. So that is the gonadotropin releasing hormone. Corticotropin releasing hormone regulates ACTH secretion to activate the sympathetic nervous system. It's protective, which minimizes the risk of miscarriage due to maternal immunological rejection. So that's important to kind of have that protective factor. Growth hormone releasing hormone, which is GHRH. This stimulates production and release of growth hormone. And then you have growth hormone inhibiting hormone, which you think, inhibits the release of growth hormone. Thyrotropin releasing hormone regulates thyroid hormones, which is your T3 and T4, and it stimulates the TSH, the thyroid stimulating hormone. Prolactin inhibiting factor is also known as prolactostatin, and it inhibits the synthesis and release of PRL by the pituitary gland. TSH regulates endocrine function of the thyroid gland. The ACTH, which was mentioned previously, this controls development and function of the adrenal cortex. PRL, which I just mentioned, stimulates the maturation of the mammary glands during pregnancy. It initiates milk production, also provides some inhibition to the stimulation of the follicle stimulating hormone and luteinizing hormone. So really that PRL is for lactation, really. Growth hormone stimulates growth and cell reproduction, and then gonadotropin, the FSH and LH we're going to go over more on the next slide. So I mentioned those on the previous slide. These are really hormones of the menstrual cycle. So these are hormones that are going to help mediate that menstrual cycle. So follicle stimulating hormone, it helps control the menstrual cycle and stimulates the growth of eggs in the ovaries. Estrogen stimulates proliferation of the endometrial lining of the uterus, and that's what causes it to thicken as the uterus prepares for pregnancy. Luteinizing hormone, this is secreted after ovulation by the anterior pituitary gland, and it stimulates development of the corpus luteum, And then progesterone is secreted by the corpus luteum and prepares the endometrium for the fertilized egg to implant and grow. So these are more related to the menstrual cycle. Then there are other hormones. We have HCG, human chorionic gonadotropin, which is also called the pregnancy hormone, because this is what signals the body to stop menstruation, and it begins to thicken the uterine lining for the embryo. This is what can be detected in the blood and urine about 10 to 11 days after conception, with levels being highest around 10 weeks of gestation. So these are the levels that are used for home pregnancy tests and also in doctors' offices to diagnose the pregnancy. So when you're taking a pregnancy test or they're checking levels at the doctor's office, this is what they're looking for, is HCG. Prostaglandins, these are actually lipids that have hormone-like functions. They cause contraction of the uterus during menstruation, which sheds the uterine lining, and these also play a part in the initiation of labor. Relaxin, this is the hormone I was talking about earlier, which relaxes and loosens the muscles, joints, and ligaments in the pelvis as it prepares for delivery. So that's the specific name of the hormone that would be released for the pelvis, so relaxin. Inhibin is, this inhibits the release of follicle stimulating hormone, which softens and lengthens the cervix, as well as promoting the smooth muscles of the uterus to relax. And you can look at page 35. Table 2.1 shows you these hormones as well, specifically related to female reproduction. So we're going to spend a lot of time on this slide, and we're going to do this in class as well, talk about this a lot in class as well, different birth control methods. So nearly half of all pregnancies in the United States are unplanned. So nurses can be instrumental in providing the proper education to determine the best contraceptive method for each patient. So part of what we are there to do is listen to our patients and help guide them in making the proper decision for them. So we're going to discuss all different types of methods. We're going to have behavioral methods, barrier methods, hormonal methods, and then permanent sterilization methods. And if you look at this picture on the slide, look at the very bottom. You'll see the most effective, where it says sterilization methods, and it goes all the way down to least effective, which is natural rhythm method. So we're going to kind of start there with what we call behavioral methods. So these include actions that women women and men together, take to prevent pregnancy. So this is not the use of medication or equipment at all. Okay, so these are just behavioral methods. These are least effective in preventing pregnancy. Okay, so let's talk about what some of these are. The fertility awareness methods, these involve identifying the beginning and end of fertile periods, and then either abstaining or using a contraceptive method during those fertile times. So natural family planning, which is listed here on your slide, this is kind of a subset of this method. Okay, so it's really avoiding or having abstinence during those fertile periods. So these fertility awareness methods, they can be done by a lot of different ways. Some people use a calendar. Some people use what's called the standard days method, ovulation detection, basal body temperature method. So there's a lot of different ways that this family planning, natural family planning, can be done. They do have like the ovulation kits that you can buy that will kind of determine when you're ovulating. But I do want to point out the basal body temperature method. So this is where the woman will monitor her basal body temperature, okay? It's very important that she understands, and this is where education comes in, she has to measure her basal body temperature every morning at the exact same time before she gets out of bed. So if this is the method that is chosen, you have to make sure she understands that it's important to measure that basal body temperature every morning at the same time before she gets out of bed. Okay, so that's where that education comes in, and that's what's important to understand about that particular method. So that was the basal body temperature method. Okay, then you have there's also something called lactational amenorrhea method, LAM, lactational amenorrhea method. So this is a temporary method that works best if the mother is exclusively breastfeeding. So this would be after she has a baby and she is exclusively breastfeeding. She also has not had a menstrual cycle since her delivery of the baby, and the infant is less than 6 months old. So that can be one of those options used initially after delivery, but you have to be very careful because once she starts having the menstrual cycle, that option can no longer be used. And then abstinence. This is the only contraceptive method with 100% efficacy, but it does require commitment and self-control. So 100% effective, but you have to be committed and have self-control. Okay. So moving to the left, we're going to talk about barrier methods. So barrier methods block the sperm from reaching the ovum, and some of these methods also offer protection against STIs. These are not as effective because of user error. So you see it's right next to the natural rhythm methods as far as effectiveness because there is user error with these. So let's talk about a few options here. The diaphragm is about 83% effective. It must be fitted by a trained healthcare provider. So it's a dome-shaped device that covers the cervix, and it can be inserted into the vagina up to 6 hours before intercourse. It must also be filled with spermicide before insertion, and it has to remain in place for at least 6 hours after intercourse. So that would be a diaphragm. It's initially fitted by the healthcare provider, but then it can be inserted by the woman herself up to 6 hours before. Then there's a cervical cap, and you can see these pictures on here on the slide. There's a cervical cap. This is a thimble-shaped silicone device that fits firmly around the base of the cervix that is similar to the diaphragm, but it's smaller. So this is the only one approved in the United States. It's actually called the FEM cap, F-E-M cap, okay? It's the only one that's approved in the United States. And it also has to be left in place for 6 hours following intercourse. And then you have condoms, which are on the top picture here. These are made of multiple materials. There's latex, polyurethane, there's some natural membrane materials, and male and female condoms are available for use. Spermicides, which I mentioned previously, these are gels, creams, or foams that reduce the motility of sperm. So those would be used with the diaphragm. And then there's a contraceptive sponge, and you can see the sponge picture here on the slide as well. This fits over the cervix and can provide protection for up to 24 hours. So the contraceptive sponge can provide protection for up to 24 hours. So now we're going to move over to hormonal methods. And on this picture on your slide, you have short acting and long acting. So these hormonal methods include the release of some type of hormone, and they come in a variety of different forms. So we're going to talk about the different forms. So oral contraceptives, we're talking about the pills. They suppress the action of the hypothalamus and the anterior pituitary, which causes insufficient secretion of the FSH and LH, those are the two hormones, and it also thickens the cervical mucus. So education has to go along with this. So you can see that there's a lot of education that goes into all of these, okay? But specifically related to the oral contraceptive pills, we have to educate the woman that they should be taken at the same time every day, okay? Certain medications interfere with the effectiveness of the birth control pills. So think about antibiotics, anticonvulsants. Those two types of medications in particular will decrease the effectiveness of these birth control pills or oral contraceptives. So antibiotics and anticonvulsants, it's very important that you educate the mom or the woman, not the mom, the woman on those things, because that would be important to understand. Also, a baseline blood pressure should be obtained so that her blood pressure can be monitored while she is taking these birth control pills. Now, there are contraindications to using oral contraceptive pills. This would be, look on page 48. Let me flip over there really quick. Look at page 48 in your book. There are the bullet points here on page 48 on the right-hand side. These are contraindications for using oral contraceptive pills. Especially, there should be precaution if the woman is over 35 years of age, but you can look at the rest of these as well. So just keep that in mind. There are contraindications and education that go along with these oral contraceptive pills. Okay, so there are combined pills, which would be combining different hormones. And then there are low dose progestin only pills, low dose progestin only. So these are also called the mini pill. It does not contain estrogen, it only contains progestin. And these can be used during breastfeeding. So that would be a reason that the woman would use those. Then there is a transdermal contraceptive patch. So this is a patch that is placed on the skin. It delivers a continuous level of hormones, and you put it on for 3 weeks, and then you remove it for 1 week, and you have to rotate the sites of where you place the patch. There is a vaginal contraceptive ring, which is a soft and flexible ring inserted deep into the vagina by the 5th day of the menstrual cycle. It is left in place for about 3 weeks, and then it's removed for 1 week. So if you look on page 50, you can see that there's patient education related to the contraceptive ring. So they're taught how to insert it. That's part of the education, is how to insert it and how to remove it. Then there are injectable methods. So on your slide here, it shows the shots. Depo-Provera is a progestin-only long-term contraceptive. It says short-acting, but it's considered long-term. So it would be a contraceptive that is given IM or sub-Q every 3 months. And then you have Nexplanon, which is implanted under the skin of the upper arm, and you see the implants here on the long-acting method, and it does last up to 3 years. I'm not sure how often that's used any longer. It has been used in the past, but I'm not sure how much that is used now. I'll have to do some more research about that. Then they have intrauterine devices, which are called IUDs. This is a small T-shaped plastic device that is inserted into the uterus, and it's left in place for an extended period of time, depending on what type of IUD it is. And I'll explain a little bit more about that in a second. The IUD is considered about 99% effective. So if you look on page 50, the picture at the bottom, figure 219, shows you what it looks like when the IUD is in place. It has a little T shape at the top. So there are 3 different types. Okay, so you have the Mirena and the Scala, or these both release progestin. So the Mirena and the Scala. The Mirena must be replaced every 5 years, and the Scala every 3 years. Okay. Then there's the Copper T, also called the Paragard, and that one actually can stay in place for 10 years. So you have the Mirena and Scala, which Mirena is 5 years, Scala is 3 years. The Copper T must be replaced every 10 years. So let me give you this little mnemonic to help you remember how to educate the woman on signs to report if she has an IUD. So the mnemonic is called PAINS, PAINS. Okay, now this is for the IUD. These are symptoms that she would report. So P stands for period late or pregnancy. A stands for abdominal pain or pain with intercourse. I stands for infection, exposure, or vaginal discharge. N stands for not feeling well if she has fever or chills. And S stands for strings missing, or if they're shorter or longer than they were, the IUD could possibly be expelled. So if you see in the picture back on page 50, there are little strings that hang down out of the cervix. So if those strings are missing, or if they are not in the same place, it could mean that the IUD is not correctly placed any longer. It may have moved. So that would be a reason to go to your primary physician as well. And page 51 actually shows you a patient education box on page 51. Then there's something called emergency contraception. So this would be protection against pregnancy after intercourse has already occurred. Okay. There's an emergency contraceptive pill. It is available without a prescription. It's called Plan B. And then a copper IUD can actually also be inserted up to 5 days following unprotected intercourse, and that will protect from pregnancy as well. And then the very last section of this slide, all the way to the left, are sterilization methods. So these are irreversible and most effective. So for the females, it's a tubal ligation, and for males, it's called a vasectomy. And these would be permanent, irreversible, but they are most effective. Okay, moving on to clinical termination of pregnancy. So a clinical termination of pregnancy or abortion is a procedure performed to deliberately end a pregnancy before the fetus reaches a viable age. So legal definition varies from state to state, like I mentioned previously, but usually that's somewhere between 20 and 24 weeks of what is considered viable age. Now we're talking about gestation. So let me talk about the different types of abortions that there are. So an elective abortion is performed at the woman's request. A therapeutic abortion, which I mentioned previously, is performed due to the risk of maternal or fetal health or disease. So surgical termination of pregnancy is vacuum aspiration, which is the most common method for the surgical abortion for pregnancies up to 12 weeks gestation. So vacuum aspiration, that's the most common. Abortions performed between 8 and 12 weeks gestation require mechanical cervical dilation after a local anesthetic. So the cervix has to be dilated if it's between 8 and 12 weeks gestation. And you can look at page 53, the patient education box for complications of abortion on page 53. Then there is a medication or a medical termination, which is an alternative for the surgical form of abortion. A medication abortion can be performed during the first 7 to 9 weeks of the pregnancy. And these medications include mifepristone and methotrexate. This is not the ideal choice of abortion for adolescents because of the legal concerns related to that. So just keep that in mind when you're talking about the different types of abortions. And nursing care. So emotional support is very critical that we give as nurses to the patients when they're making this decision. It extends through the procedure and then after the procedure as well. We need to counsel the patients about potential complications like excessive bleeding, risk for infection, and we really want to reinforce the importance of follow-up visits. We want to check on them emotionally, check on them physically, so really reinforce those follow-up visits and how important they are. Infertility. So to diagnose infertility, there are certain parameters. So let me explain what this means. So infertility is diagnosed if a woman aged 34 or younger has not conceived within 12 months of actively attempting pregnancy, or within 6 months if she is 35 or older. So it depends on the woman's age. So 35 or younger is 12 months, 35 and older is 6 months. Infertility can be due to a lot of issues. So with the female, it would be related to things such as endometriosis, ovulation disorders, maybe tubal occlusions. With the male, it could be decreased or insufficient sperm count or even sperm motility. So it can be related to the male or the female, okay? So for female infertility evaluation, if you look to page 55 on that right-hand column, it shows you labs that will be done during that infertility evaluation of the female. And then if you flip over to page 56, it shows you different methods of evaluation. So pelvic exams, there's different types of tests. There's an ultrasound. They're looking at hormone function. So all of those things can be done during the female evaluation. And then for the male evaluation, the infertility starts with a semen analysis to assess the quality and quantity of the sperm. So the female and male are different as far as how they're evaluated, and then they go further from there based on the results. So treatment options are going to depend on the cause of the infertility. There are medications, a number of medications that can be used. Some for the female to induce ovulation, some that can supplement her levels of hormones, some that will prepare the uterine endometrium for implantation of the fertilized egg, and then some that will actually support the pregnancy following conception and implantation. So there's a lot of different medications for the female. So a medication called clomiphene citrate or Clomid, CLOMID. This is frequently prescribed to trigger the release of follicle stimulating hormone and luteinizing hormone. HCG is administered to prompt that ovulation after adequate follicular stimulation. So these procedures that will stimulate the follicles, we're going to talk about in just a second. So these techniques are called, excuse me, assisted reproductive techniques. That would include like in vitro fertilization. So we'll talk about those in a second. Surgical options are also available if there are obstructions. So if the woman has endometriosis that is causing difficulty, they could do an ablation for her. So there are surgical options as well. Therapeutic insemination is also known as artificial insemination. So this involves the placement of semen at the cervical os or directly in the uterus by mechanical means. And then they give the clomiphene citrate or Clomid and ultrasound monitoring for follicle development so that they ensure that the time of insemination is with ovulation. So both of those would be used together. So the Clomid to stimulate ovulation and then ultrasound to monitor that so that the artificial insemination is occurring at the time of ovulation. And then the assisted reproductive technologies that I talked about earlier, these are different types of treatments that can be done where they actually put the egg and embryos together, possibly outside of the body. So the egg is fertilized outside of the body. The embryos are handled outside of the body, and you can see those procedures in the box on page 57 of how that is done. So that would be more of what you think of as in vitro fertilization. So there are a couple of knowledge checks. So look at these, and we're going to talk about these in class. So there's one here, and then there's a matching here. So you're going to match column A, the left-hand column, the A, B, C, D, E, to the right-hand column, which are the numbers 1 through 5. And then there's one last knowledge check here that will be select all that apply, and we will go over these answers in class. And that is the end of chapter 2.